Hey guys, in this video we're getting ready to palpate the SC joint. So when we palpate the SC joint, we're going to do an A to P palpation, a P to A palpation, S to I to S, and a long axis distraction. Now this is a pseudo long axis distraction, and we'll explain that a little bit more when we actually get in to the palpation. So to start, we're going to start with an A to P palpation. For the A to P palpation, docs, I want you to stand at the side of your patient here, and you're going to be borrowing your patient's arms. I want you to use a hypothenar contact on the proximal clavicle. Okay, remember that the SC joint is the proximal clavicle and the sternum, or more specifically the manubrium. So if I'm standing here, I want to just have my patient's arm be nice and relaxed. I always tell my patient to give me a spaghetti noodle here. That way I know that this arm is relaxed. They're not carrying tension through the muscles of the shoulder complex. And I can use that hypothenar contact as I elevate the arm here, and I'm just going to simply compress slightly there at the proximal clavicle and feel for an A to P glide of that SC joint. The next palpation is a P to A. So during a P to A palpation, you look very similar, with the exception of you're bringing that arm up here, and I'm going to elevate the arm like this. When I elevate the arm here, what it does is takes that clavicle and brings it up too. When it brings the clavicle up, I'm able to palpate just behind the clavicle and use that contact to pull. Please be careful here because we're talking about skin over bone. So there's not a lot of tissue to play with, and this can be very tender for our patients. So we need to be able to communicate with our patients. I use 3 finger pads behind that clavicle to move P to A. I don't want to grip and pull. I want to move with my distraction arm here. So I will distract, create a contact here, and then I'm going to distract the arm and pull with this hand at the same time. Okay? The next palpation is an S to I. So during an S to I, we're going to use the fact that the SC joint is a saddle-shaped joint. And we're going to palpate the superior proximal clavicle. So as I'm palpating that superior proximal clavicle, I'm using finger pads again. I'm going to abduct the arm. And as I abduct the arm, I'm adding pressure here with that digital contact on that proximal clavicle. I'm adding pressure and I'm compressing as I abduct. When we abduct the arm, the clavicle naturally depresses slightly because it is a saddle-shaped joint. It's naturally wanting to move S to I. So we're just going to follow it with our contact and add a little bit of overpressure as we do that. When we do our I to S palpation, we're going to adduct. We're going to bring that arm in. We're going to use a thumb contact. So I'm going to use a thumb contact on the proximal clavicle. Again, a very tender spot on most patients, so we need to make sure that we're not using a ton of force through my digital contact here. Instead, I need to use this motion that I'm using with the arm when I adduct it to help me feel that palpation as I go through. Additionally, I'm going to curl my fingers in here, and the reason I'm going to do that is because if I have them out here, my hands are resting across my patient's chest near her throat. And no matter how familiar you are with your patient, you never want to bring anything into question about your intentions. So please always make sure that you have your fingers in here so that your patients understand what you're doing. So you don't have your hands around their throat, basically. You're using that thumb palpation. We're going to adduct and add a little bit of overpressure with this digital contact here. The last palpation we're going to do is palpate that SC joint. I'm going to palpate the clavicle portion and then the manubrium, the sternal portion as well. And I'm going to do long axis distraction. What this means is it's going to feel like it's distracting. It's not really. As I do horizontal abduction here, So the arm's out at about 90, and I'm going to drop it back. I should feel that SC joint open up is what it feels like. What it's really doing is rocking back, but I need to be able to make sure that that motion exists. Since this is a motion that exists at the SC joint, I want to make sure that it still is there for my patient. So this is the palpation of the SC joint.